So now I'd like to start our presentation, and I'd like to introduce Dr. Philip Harvey. He's the Leonard Miller Professor of Psychiatry and the Director of the Division of Psychology at the University of Miami Miller School of Medicine, as well as a Senior Research Health Scientist at the Department of Veteran Affairs. He's the author of over 1,000 scientific papers and abstracts, and he's written over 60 book chapters. He has edited 6 books and written 4 books on the topic of psychological assessment, schizophrenia, and aging. He has also served on several National Academy of Medicine panels and headed a blue ribbon panel jointly launched by the Social Security Administration and the National Institute of Mental Health, with a goal of streamlining the process of award of Social Security disability to people with severe mental illness. His research has focused for years on cognition and everyday functioning, and he has written on many topics, including cognition and aging and schizophrenia, and interactions with technology in mental health areas. He is also studying the effects of cognitive enhancing agents and cognitive and functional skills training in various conditions, including healthy aging, mild cognitive impairment, dementia, schizophrenia, bipolar disorder, and traumatic brain injury. We welcome today Dr. Philip Harvey.
Great, thank you very much. I'm going to stop my video to save my bandwidth. I'll turn it back on when we do question and answers afterwards. I'm going to try to share my screen. Oh, looks like it's working. And I will go into the slideshow mode. Let me know if I'm filling up your whole screen there.
You are.
Perfect. So I'm going to integrate a few different topics that are actually intrinsically relevant, related to each other, including COVID stress, cognitive functioning, and strategies for health maintenance. We're going to address aging as well as severe mental illness. And I'm going to try to draw some of the connections that are there between the changes we see with cognition and aging and the lifelong challenges and cognitive impairment that are associated with severe mental illness. Click. We're going to talk about COVID stress, how it specifically impacts older people, people with severe mental illness, and why. We're going to talk about cognition and aging and severe mental illness and discuss the concept of cognitive health. And then show how easy it is to keep your brain young when it boils right down to it. So here we go. Let's talk about some data. Here are the basic demographics in the United States. What's happening is everyone is getting older. Although because of the COVID crisis, the life expectancy in the US dropped by a year last year, but it's still higher than it's ever been. At the beginning of the 20th century, the life expectancy in the country was 41. The reason they pegged Social Security to kick in when you were 65 is they figured that only 5% of working people would ever collect it. So it wouldn't cost the government very much. But what we're seeing now is a burst of people who are over the age of 65 and an increasing burst of people who are 85 and older. What does that mean? What it means is there's going to be lots of people who are over the age of 85 who are then confronting the naturally occurring age-related changes in cognitive functioning. What's happened, though, is with the COVID crisis, we've discovered that people who are older are a particularly vulnerable population, and that even though life expectancy in general has been increasing, and I don't know why this is happening, I didn't even touch anything. Well, although life expectancy has been increasing, the people who are much older have been hit much harder by the COVID crisis. What do we know about aging? Aging is a process of gradual changes in the structure and function of organisms that occur over time. It occurs in any organism who has a long enough lifespan. Change can encompass both decline and positive developments. It is true that wisdom increases with age. What your grandmother told you when you were younger is actually true. You can measure it with neuropsychological assessments. People are better at solving problems that involve accumulated wisdom when they're 65 than when they're 35, and better when they're 80 than when they're 65. It's complex, though, and multifaceted. Some things don't get better as you get older, and there are things that have to be adjusted to because you can't really get around it. It doesn't occur in a vacuum. It's influenced by context and life experience. One of the things that's happened in the last few years is that technology has been so absolutely pervasive that many people are challenged by just performing everyday tasks. If you want to get in touch with the Social Security Administration, you have to do it on the internet. Otherwise, you have to stay on the phone for 5 hours, and by then your battery's worn out. However, people who are 85 years old may have retired from their job before they had voicemail at their desk. So the idea of going online entirely to manage your retirement plans is certainly a major challenge. So here's a little sample of people who are older nowadays. I replaced one president for the other, but at the same time, they still are older people. As you see, the Rolling Stones are all on Medicare at this point. And Betty White just turned 99 and she's still with us. So what we're seeing is that tons of people whose lives we have followed since they were very young are older now. And many of them are acting in ways, for better or worse, that aren't much different than happened over the course of their entire lifespan. Today and tomorrow's older adults are better educated, more diverse, healthier, and more active than previous generations. A lot of them are involved in full-time or part-time volunteer activities. Many are pursuing new hobbies, and a lot of them are involved in caregiving, some of them for their parents. So when you think about that, a lot of people who are in their late 60s have parents that are still alive, which would have been almost inconceivable at the time Social Security went on the books almost 100 years ago. So it's a very different environment. Most jobs have eliminated mandatory retirement ages. So a lot of people even people who have planned well for their retirement are planning on working into their 70s and even 80s at a regular job. But there are some things we all need to deal with. Fluid ability and crystallized ability are two different sources, two different domains of cognitive functioning. Crystallized ability is what you learn over the lifespan. It's facts, it's vocabulary, it's information. We ask you, what's the capital of Italy? If you knew it when you're 35, you'll know it when you're 95. However, fluid ability, which is the ability to solve problems, to process information, to have rapid processing speed, decreases with aging, and that's a large decrease. So what we see is there's a real trend downward. And so the ability to learn new information is challenged relative to the ability to utilize information that you've acquired earlier in your life. So when we think about ways to make life easier for older people, making life easier for older people does not force them to acquire new skills in domains where they've never had those skills beforehand. My kids both had iPhones and computers before they were 6 years old. Technology is part of their crystallized ability. So the ability to use a new device is something that they've confronted their whole life. People who are getting a smartphone for the first time when they're in their 80s are confronted by the fact that when you get something new from Apple, there is no user's manual anymore. The only instructions you get from the manufacturer are how to charge the battery. So what happens in schizophrenia is there's this amazing link to what we see in aging. There are multiple domains of impairment. The impairment starts very early in the course. More abilities are impaired than unimpaired. But what we see is that crystallized intelligence in people with severe mental illness is also not compromised. So what people have learned to date is something that they can retain. However, because their ability to learn new information is compromised much earlier than healthy people, what we're seeing is that their crystallized knowledge is less than you'd expect, given their age and educational attainment. But what we need to think about is that the challenges of aging and the challenges of severe mental illness in terms of cognition are quite the same. That the challenges are in working memory and processing speed and learning new information, but not in remembering things that you already learned. So let's talk about COVID, because COVID operates on a substrate that is relevant to both aging and severe mental illness. We're at 500,000 deaths Next week is going to be close to a full year of lockdown across the country. We've seen the politicization of treatment, vaccination, and prevention, complete uncertainty about what's coming next. Today was the anniversary of the day that President Trump announced that there were going to be 25 COVID deaths in America and that the virus was going to disappear. That was commemorated on the front page of a newspaper that didn't like him very much when he was in office, the New York Daily News. But it points out how things have spun off in multiple directions, which also makes it much more challenging, particularly for people who are used to hearing things that might be true in the media, have to deal with it. So one of the things that we encounter is that historically, people who are in their 80s and 90s, when they were watching the news on television in the 1960s, there was no reason to believe that anything that you heard wasn't true. Walter Cronkite wasn't coming on television and saying something that just was absolutely false. So one of the abilities that people who are older don't have is the ability to judge whether information that's being presented by authoritative sources is actually completely fictitious, because it's not a skill they had to develop. It's not a skill that you get from surfing the internet. If you go on Twitter, you go on Facebook, it's really easy to see that most of the stuff that you see doesn't have any factual basis. But if you're used to believing what you hear, then like many other older people, you can fall victim to knowledge scam, just like phishing scam. I went to my mother's computer one time, she's 90 now, and she had 400 processes running in the background. And I said, well, what were you doing? She said, well, I kept getting emails from Hewlett Packard and from Apple telling me to click on the link and they'd update my computer. So I just clicked on them. And so it hadn't occurred to her that this is something that is just, not the case. The uncontrollability and unpredictability of the COVID crisis causes the stress. There are a lot of caregiving challenges. Older parents, younger impaired children. There's an inability to get adequate information. We can't tell when vaccines are going to be released. We don't really know from information that's coming from the government at either local, state, or federal levels what's actually true. When's the vaccine going to be released? And there's also, of course, frustration with others who are refusing to cooperate. Some people won't socially distance and some people won't use masks. And where I live in Palm Beach County, a whole bunch of the parents of the children that my kids go to school with have managed to get themselves vaccinated by buying vaccines from concierge doctors. So there's a real frustration with the fact that some people who are even potentially sick in their 50s can't get vaccinated, but other people who are in their 40s are able to get a vaccine and then a second vaccine just because they can write the check for it. So how do you mitigate these adverse consequences? Well, obviously, cognitive exercise is important. Physical exercise is important, and distance social contact. One of the things that's happened is that for a lot of people in the world, they haven't had direct social contact with people. With those of us who use technology all the time beforehand, we switched to Zoom fairly fast. If you live in the right neighborhood, you can still walk. If you're working 12 hours a day still and Zooming, you're getting plenty of cognitive exercise. If you don't have a computer, if you have a disability, if you're living in assisted living, a lot of those things are just not an option to you. So we need to talk about what the benefits are and how you can get them to deliver them to yourself. Well, the biological substrate of this stress is probably inflammatory consequences. Inflammation is associated with stress and cognitive changes. It's associated with cardiovascular risk. People who are abused when they are younger, physically and sexually, have greater inflammatory responses when they're older. Inflammation correlates with having reduced immune response, cognitive changes, as well as reduced response to treatments that are otherwise effective. When you're having an out of control immune response, weight gain and increased substance abuse only exacerbate that. It's been a remarkable lockdown for people selling alcohol, high-end alcohol, cheap alcohol. Alcohol sales are up by 33%. Weight gain on the part of some people, the average weight gain has been 15 pounds for people who are locked down, whereas some of us live in a place where we can exercise. Other people, where you where you need to have someone assist you to exercise, it's just not been possible. So there's been a whole set of substrates that impact on older people, on people with severe mental illness, and people with other physical challenges that's made this lockdown crisis worse. And we did some research on this. We were doing a study that we thought was really quite creative and interesting. We identified 3 different samples of people with severe mental illness, people with schizophrenia and bipolar disorder across 3 different places in the country, and a sample of aging people with bipolar disorder in San Diego. What we had done was we knew these people pretty well. We gave them a smart device and we paged them 90 times over 30 days, 3 times a day. And we asked them, where are you? Who are you with? And what are you doing? And then the crisis hit. So we knew very well how these people had been doing right before the pandemic lockdown. So what we did was we called them up. We knew they had a phone because we'd given them one and they still had it. And so we called everybody on the phone that they were using for our study, and we asked them a bunch of questions about what they were doing. So we had a very solid baseline, the kind of baseline that you rarely have when you do a research study, of 30 days of 3 times a day surveys about who, where, what, and how. Two different studies, one focusing on mental health with pre-existing severe mental illness. The other one is on psychological distress and whether or not that motivated people to engage in preventative behaviors. Both have been published. Both are open access. You can easily look them up and take a look at them. First of all, there is some good news. Stress levels are not increasing nearly as much in SMI individuals as in the overall population. Our population was already socially isolated. The participants that we sampled with schizophrenia were home and alone on 70% of the surveys that they answered, but now they're not being stigmatized for being isolated. Before, if people wanted them to come over and do something, they said, oh no, I'd rather stay home. It's like, come on, what's the matter with you? Now it's like, oh, no problem with that. So what we found was that people who had a high proportion of surveys answered when they're home and alone were telling us they're doing fine. In fact, they told us they were doing better. However, preventative efforts are not being engaged in. The participants are telling us they are not wearing masks, they're not socially distancing, they don't know what to believe, they're getting internet information, they're already thinking that they're under surveillance because they have psychotic symptoms, and now they're hearing that if you get injected with the Moderna vaccine, it's going to put a chip in your brain so the government can control your behavior. So the preventative efforts are being the disinformation efforts are actually engaging this particular population of people who are vulnerable to believing things that other people might not believe anyway. And now we're seeing that millions of people are believing stuff that would have been seen as probably symptoms of mental illness years before. So let's talk about the implication of aging and severe mental illness. Life expectancy is reduced by about 20 years in schizophrenia, and it's reduced by the factors we talked about before. Exercise, eating, and diet are considerably impaired, and they're related to cognitive deficits and impairments in functional capacity. What's really interesting is that in specific, shopping and cooking skills seem to be excessively related to cognitive functioning in people with severe mental illness. Type 2 diabetes is really common, and weight gain is linear over the lifespan. And there's lots of correlates of obesity, including inflammation. The 20-year follow-up data on the Suffolk County project paint the picture. These are participants who were recruited during their first ever psychiatric hospitalization. And then they've been followed up for the subsequent 30 years. At the 20-year evaluation, they did a comprehensive physical exam looking at weight and consequences of metabolic syndrome. And so what you're seeing here is that we're getting up to about 65% of the participants are obese at the 20-year follow-up. And that's not that long down the road. The people with schizophrenia were only 21 when they were recruited. So we've got a 62% rate of obesity by the early 40s. More challenging is the fact that people who were overweight at the time they were first recruited were essentially at higher risk for developing obesity. And one of the really interesting things that we found, it highlights the importance of maintenance of good health and physical activity over the lifespan, is there was a cascade toward unemployment at this 20-year follow-up. The two biggest predictors of not having a job 20 years after your diagnosis were your waist circumference and the ability to get up out of a chair. So we used a physical ability battery and examined these participants. And what we found was that there was a cascade starting back 6 months after your diagnosis. The people who were heaviest right after they were diagnosed were the ones who were most likely to have a large weight circumference and have mobility challenges in their 40s. So it tells you it is never too late to intervene on weight gain and physical fitness, and it really needs to be prioritized early in the illness, because it's a scary thought that what you weighed 20 years ago is the reason why you're having a hard time getting a job right now. And these people have had essentially no preventative physical interventions. They have just been treated in the standard New York State mental health system, and this is the consequence of that. Type 2 diabetes is bad for your brain anyway. In people who do not have severe mental illness, when you compare diabetic and non-diabetic individuals, what you see is that there's a very substantial correlation between cognitive functioning and your hemoglobin A1C level, but it also is mediated by the size of your hippocampus. So having higher A1C levels, even in the absence of any other severe mental illness, leads to hippocampal atrophy and leads to impairments in cognitive functioning. So the idea is you really want to avoid this, and the risk factors for diabetes, severe mental illness, and the treatments, as we saw on the last slide, are clearly related to that. Is it all gloom and doom? No, it's not. We're going to get to some intervention strategies that seem to work in just a minute. Well, what are they? Computerized cognitive training. It's widely distributed now. It's been rolled out over the entire lifespan. Interventions have started with people who don't even have a diagnosis yet, but are identified as having attenuated psychosis syndrome. So it's widely available. You can download it off the internet. It runs on any device now. And as we're going to talk about in a minute, it's extraordinarily inexpensive. There's very little you can do for yourself that costs less than computerized cognitive training. The most encouraging study of them all was the active study. The active study identified people who were over the age of 65 who did not yet have cognitive changes. They were trained on one of three different interventions: speed of processing, reasoning, and memory. And the speed of processing training, which was delivered completely over the computer and is commercially available, resulted in improvements in cognitive abilities that lasted for 10 years. 10 hours of cognitive training when you were 65 was detectable 10 years later when you were 75. And the risk of developing dementia in the people who received speed training was reduced by 43%. It's a randomized trial. These people didn't have dementia in the first place. So this training is responsible for long-term, very substantial benefits. And the reason for that is twofold. Number one, it activates your brain. And what happens is when your brain gets activated, you tend to do more cognitively active things. But also what they found was that people who received the speed training became better able to drive and better able to perform activities of daily living than they were beforehand. They didn't learn new activities. They didn't learn how to drive when they were 70 for the first time after getting speed training, but accidents, infractions, and giving up driving was markedly impacted by that. So cognitive remediation therapy is a systematic, structured program of training and education aimed at enhancing cognition. It's got several critical features: organized training, specific learning objectives, and consistent stimulus delivery. Everything that works shares the following characteristics: dynamic difficulty titration, feedback, and computerized delivery. What's dynamic difficulty titration? As you do better, the computer program makes the test harder for you. So you're always succeeding at a level of 80% correct. If you're having a bad day, all of a sudden the task gets easier enough so you can actually do it. If you're having a great day, it pushes you to the point where you make gains. You get feedback every response and every condition. And the computerized delivery is critical because a human couldn't titrate difficulty like that. What's not CRT? Reading, Sudoku, standard video games? Well, why not? If you're doing reading, shouldn't that be good for your brain? Right, but you could read the same thing over and over again, and what would you learn? The learning games actually are generally based on crystallized knowledge. So a lot of games that are trivia games, which test how much you've already learned, not teaching you to learn new things. And standardized video games, some of them are good, some of them are not. The ones that are good are the ones that only push you back a little bit when you fail. But if you're participating in a video game and when you crash, it sends you back to the beginning, then all your training gains are negated because you're just going back to the baseline. You need training at any level of difficulty, continuing to train when goals are met, no difficulty challenge in limited domains, separate the things that don't make your brain better from the things that do. So in the active trial, it's healthy older people, structured training intervention, easy to complete, commercially available. You can start tomorrow in the Coral Gables Community Center for free. As soon as the COVID crisis is over, they have the brain gym in both Coral Gables and Key Biscayne. And if you want to do it at home, it costs $8 a month. $8 a month is not bad. The copayment for many doctors' visits is $50. There aren't any medicines you can buy for $8 a month that would enhance your cognition. So I think it's worth considering. What we've done is we have done augmented cognitive remediation for people with severe mental illness based on the principle that if you've never played the piano before, and I gave you 15 IQ points, you would be smarter, but you wouldn't know how to play the piano because you got to learn how to play the piano. And our argument is that an ATM, internet shopping, or other skilled tasks have the same status as playing the piano. If you've never done it, how are you going to learn how to do it? So what we did in this study was we randomized people with schizophrenia to receive cognitive remediation and fake skills training with fake cognitive remediation, and active treatments in both. And what we found was that neuropsych performance on a computer, on a paper and pencil neuropsych assessment improved by the equivalent of about 10 IQ points over the course of a 12-week intervention. We also found that the ability to perform everyday functional skills improved when you were taught them as well. But learning new functional skills didn't improve your cognition. Learning new cognitive skills didn't improve your functional ability, but if you got trained in both, your cognition improved, your ability to perform everyday functional skills improved, and your real world functioning improved to an extent that your case manager could detect it at the end of 12 weeks of intervention. So people who were concurrently trained in cognitive abilities and then taught functional skills like paying bills, managing money, using the telephone actually improved in real world functioning over a fairly abbreviated treatment period. So other things that are even more important have been shown to benefit from cognitive remediation. Psychosocial interventions such as vocational training, some are available, but the response rate is really low. My colleague Susan McGurk, who was a postdoc with us at Mount Sinai and now is a faculty member at Boston University, did a really interesting study where she took people with schizophrenia who'd been given a structured employment intervention and had not benefited from it. And then she randomized them to receive an augmentation of their vocational program or just simple computerized cognitive training. And what you see is the people who receive the computerized cognitive training improve rapidly and persistently, and the intervention ended at 6 months. So people who got a job after getting computerized cognitive training kept it for the next 18 months, even though the intervention was over. So the best intervention for improving your brain functioning is employment. And the best way to get employment is to get a structured intervention targeting cognition and targeting work skills. So you see that we have both increased rates of unemployment and increased weeks of employment in people who were chronically and persistently unemployed and who'd received 26 weeks of job training and hadn't gotten a job. So we're seeing a very rapid change in people who'd got a big intensive intervention beforehand that just didn't happen to do them any good. So the bottom line is this: 14 hours of speed training in healthy older people leads to detectable cognitive benefits 10 years later. The risk of dementia gets reduced by 43%. You can deliver it at home to impaired populations. A 40% increase in employment in severe mental illness compared to job training alone, $8 a month. So the numbers certainly add up as far as I'm concerned. But actually, I got a couple interventions for you that are even cheaper for that. And that's what we're going to talk about and close there. So you don't have a computer, you don't have a tablet. Well, there are other alternatives. There's a large research literature now on exercise, and not necessarily killing yourself physical exercise and its benefit on both cognition, function, and longevity. It seems as though there may be a bell-shaped curve or partially bell-shaped curve regarding intensity of exercise. People who don't exercise at all have high rates of cardiovascular disease, but there is a high rate of cardiac arrhythmia and other consequences in people who are long-term intense exercisers. AFib rates are actually elevated in people who have had extended periods of intense exercise. So the idea is, if you've never run a marathon, you don't need to feel bad, because some of these other interventions and just activity monitoring things suggest that moderate range physical activity that's within a lot of people's capability has a lot of benefits. So this is the cardiovascular health study. Unfortunately, there we go. My video monitor is hanging out over my titles. It's a longitudinal study of 876 older people, mean age of 78. It examined exercise patterns using systematic self-reports in a 5-year longitudinal study, and it related exercise activity to brain structure and risk for MCI or development of Alzheimer's disease. So basically what we see is that higher volume exercisers, and this is exercise measured by walking, not necessarily running, had larger gray matter volumes at baseline, and they increased over time. Gray matter increased over time as a function of exercise activity. The risk for dementia was reduced by exercise by an odds ratio of 2, and pure calorie count, not type of activity, was the predictor. Walking was just as good as running. Sitting is what's unhelpful. And unfortunately, what we see is a lot of people as they get older, and a lot of people with severe mental illness, do a lot of seated multitasking. And even seated unitasking is not necessarily good for you. But what we're seeing here is that just getting up and moving around, doing the kind of activity that can be measured with a Fitbit or other actigraph, predicts increases in your brain volume starting when you're 78, not starting when you're 24, but starting when you're 78 years old. And here's where it changes. It changes in your temporal lobe, it changes in your frontal lobe. And if you want to grow gray matter anywhere, you certainly want to grow it in your temporal lobe, which manages the memory system. You want to grow it in your hippocampus, which is where memories are stored. And you want to grow it in your frontal lobe, which is where you solve problems. And so what we're seeing here is a totally naturalistic observation of the benefits of exercise in people who are definitely not running marathons to start with. And so exercise was associated with positive effects. It seems to be preventing dementia. If you want to improve your memory, grow your hippocampus. But if you want to grow your hippocampus and your gray matter, it seems like all you have to do is move, and you don't need expensive equipment. You don't really need to leave your neighborhood. We're just talking about the kind of thing that can be measured very basically. So what this shows is the interaction between increasing caloric expenditure and reduced risk of MCI or AD overlaid on the left hippocampus. So move around, it reduces your Alzheimer's risk. Numerous studies have been published recently looking at exercise and severe mental illness. We published 2. We showed in a study that you could take non-trained people and turn them into personal trainers. We took our study coordinators and we had them take people with severe mental illness to the gym in our building and have them walk. And what we discovered was that we had weight loss and increased cardiovascular functioning within the first 6 weeks. We upped the ante. We took them over to the we took them over to the Exercise Physiology Center at the main campus and then had them do high intensity circuit training. High intensity circuit training is hard, but it not only led to weight loss, it actually led to improvement in cognitive functioning over a 12-week period. High intensity circuit training is less available. It was delivered by trained personal trainers. It's an intervention that's more expensive than walking, but we showed that just hitting the treadmill, walking around outside is good. Most of the year, you're better off in Florida than any place else in the country as far as getting exercise. Some days in the summer, it's hot and it rains, but you don't have to exercise all day to get the benefits that we're talking about here. So let's talk about how this all adds up at the end. There's really no consensus on the optimal definition of healthy aging, but we know that it includes physical health, cognitive health, emotional well-being, and social well-being. We need to focus on all of these things. The COVID crisis has made it harder to focus on every single one. People who are older or who don't have access to technology are much more challenged by this. But at the same time, as the crisis winds down, we need to learn the lessons that the crisis taught us. We need to focus on increasing access to technology and things like telemedicine or even video conferencing among older people. We need to focus on the idea of giving people access to technology that's really cheap. What's it cost to have a Zoom account? It costs nothing. Zoom is free. So we're talking about a situation where these interventions are not expensive to deliver. They don't need to be supervised, and they have fairly uniform benefits. So what do? Well, first of all, you engage in cognitive activities. You maintain a heart-healthy diet, engage in physical exercise under a physician's supervision if necessary to start with. Doesn't matter what it is. Try to manage your stress. Be as socially engaged as you can be. FaceTime, mobile phone, adequate sleep. Oh, this is a note from, I actually gave this talk at the Bergamo Science Fair, and I pointed out that Italians are notoriously poor sleepers, that things go on till late at night, and then they start with espresso again early in the morning. But Italians don't have a hard time maintaining their sense of humor. Try to be adapted to change and life's transition. And here's what Keith Richards said about this. How do you feel about getting older? He said, he's not getting older. I'm evolving. So we need to keep in mind that, the demands on your time change, the availability of certain things changes. But what it boils right down to is some of these interventions that have really big impacts are cheap, they're accessible, they're social. You can go for a socially distanced walk with a mask. You don't need to run a marathon. You don't need to go at any particular time of day. And as far as training yourself on the computer and engaging in contact with other people using these apps, it's probably better than social media. Social media, as we said before, is about 70% false. When you're Zooming with someone who you know on the computer, you know who it is and what they're saying. And I think that's a better strategy than a lot of this other stuff. So I'm going to turn my camera back on, stop sharing my screen, and take any questions you guys have. And I'm back.
Kathy, if you're trying to speak, you are muted.
Okay, so I need to listen to this program again and take some steps because I've been doing that a few too many times lately. Thank you, Dr. Harvey. It is absolutely amazing. And Kate, is there some questions or in the chat or in the Q&A?
Yes, I just wanted to make sure I had responded to this correctly. Someone was asking about what CRT stood for, and I just wanted to make sure.
Cognitive remediation therapy.
Therapy. I said training, but it was, yes, therapy.
Same thing. The difference between cognitive remediation and cognitive training is that when you do cognitive remediation, you do something besides just training on the computer, right? So it's cognitive remediation if you walk and train on the computer. It's cognitive remediation if you learn a skill as well as train on the computer. But just training on the computer has not been shown to improve your actual ability to perform skills. It makes you do better on cognitive tests, but you got to match it with something to broaden the benefit.
Oh, thank you for clarifying. Okay. And then someone says that Jessica says she works at a senior center. Is there a way to offer this active training there? And is there a website for this?
Well, yes. What happens is at the Coral Gables Center and at the Key Biscayne Center, they're already doing this. They've got a thing that they call Brain Gym that's going on. And we have been doing through our UM-related startup company called iFunction, we have been doing research studies where we take older people, both help with normal cognition and with MCI, and we give them cognitive and functional skills training to identify the optimal mix of training to both improve cognition and everyday functioning. The cognitive training program that I mentioned, and I'm going to wait till everyone gets ready to write it down if they want to, is Brain HQ. So it's really Brain HQ. You can look it up on the web. You can get subscriptions. You can contact us because we are looking to expand our skills training intervention, which is combined with Brain HQ to other community centers. So we have an active outreach program going on now. I was on the phone this afternoon with an enormous rehabilitation clinic up in New York at the Manhattan Psychiatric Center, which is the largest remaining state hospital in New York. They have 1,000 patient outpatient clinic, and they have a transition program, and we're going to be implementing the skills and cognitive training with people as they're about to leave the hospital and move to a community residence. Because we know if you don't know how to use an ATM, then you shoplift at 7-Eleven. If you don't know how to use a ticket kiosk, you jump the turnstile. So these two simple skills can keep newly discharged patients out of trouble. Here in Miami, a lot of our program, a lot of our participants in our jail diversion program through Judge Leifman have money in the bank. They just don't know how to get it out. So if they knew how to get an ATM card and use it, they wouldn't be shoplifting at 7-Eleven, running out without paying at Dunkin' Donuts. They would be paying with their own money. So these are basic skills.
Fantastic. Thank you. Laurel, we will send you the recording in an email. And then there's a question, have there been studies on plant versus animal diets for cognitive health?
Well, we know that certain kinds of animal diets are not good for you because the diets associated with the traditional Western diet with high levels of cholesterol and stuff like that is associated with metabolic syndrome and things like that. Now, the Mediterranean diet is hardly a plant diet. It seems to be one of the healthier diets there are, but the traditional Western meat and potatoes diet is clearly not as good for you as a plant-based diet. It's important to keep in mind that a lot of things that look like they're plant-based are not. For example, a lot of these non-dairy butters and cheeses have a huge infusion of lactic acid in them. That's what makes them taste like butter. So if you've got lactose intolerance and you're infusing as much lactose as you would get from cream or butter in the vegan butter, well, then you have the same consequences. So just saying plant-based is uniformly better, it requires a little bit more checking, but absolutely there's a gradient of diets that are better for your brain. The ones that are better for your heart are the ones that are better for your brain too.
Great, thank you. And then Kelly is asking what the names were of the studies to be able to look up and read/review. Okay,
active is the most important one. And I've got a note here from our research group saying, from Belinda, can you read that? Belinda Robertson was in the chat. She's from our group. She's wanting to
Oh, yes. Belinda wrote, are there any research studies people can look into regarding CCT or using smart devices?
Sure. Well, we're doing a number of studies. We have one study right now at which is what we call pharmacologically augmented cognitive training, where everyone who's in the study gets an effective version of cognitive training, and half of the people are randomized to concurrently receive a cognitively active drug that might augment their response. So everybody gets an active treatment. Some people get 2 active treatments. And once again, we're looking for people to participate in that. We have some other technology-based studies that involve ecological momentary assessment, where we're having people respond to those 90 surveys that we talked about before and tell us what they're doing. We also have a follow-up study looking at augmentation of the detection of early suicidal ideation, which is also using ecological momentary assessment. Those are things that people might be interested in. And we also have a study where we're interested in people's ability to define what they mean by recovery. We're looking to find people with severe mental illness, schizophrenia in particular, but also relatives and peer specialists to tell us what they think is important in terms of recovery. Because this is funded by the FDA. The FDA wants to measure things that are important in clinical trials, and they want to find out what people with various levels of experience and with an exposure to severe mental illness think about recovery. So, and embedded in that is a sub-study looking at what people know about and think about long-acting injectable antipsychotics as a strategy to promote recovery. So anyone who's interested in any of those things, we have recruitment information readily available.
Wow, that's fantastic, especially from an organization where recovery is such a strong part of our mission, and lived experience from recovery is part of everything we do. So that's
Yes.
really great.
And that is the group of people we're looking for the most, are people who've got that lived experience with recovery. And the study is actually done completely remotely, and people are compensated for their participation. And we are just basically doing qualitative analysis of what people think is important. We don't have any necessarily things we're trying to confirm.
And so what we'll do is we'll work with you to get the links for all of those studies. And when we send out the recording to all the attendees, so you don't have to write them down now or ask questions in the chat and try to figure it out. We'll put them in that email. So we'll work with you to do that before we send out the recording.
That's perfect. And people can send us an email, or we have a number to call to get information, and people will get right back to you.
Perfect. We do have a few more questions if we're good on time.
Certainly.
Catherine's asking, you mentioned that inflammation is associated with cognitive changes. Could you elaborate how so?
Well, inflammation seems to be associated with a number of adverse consequences in the vascular system. So, for example, elevated CRP is an inflammatory marker. There's a number of inflammatory markers, but CRP is C-reactive protein, is a marker that is acknowledged by the American Heart Association to be very important in heart disease. Anything that's important in heart disease is also important in brain disease, because most things that go wrong in the brain are associated with blood flow to the brain. And so atherosclerotic processes are associated with elevated CRP, but so is exaggerated stress response. And so all of those things are linked together. And the cognitive changes associated with elevated inflammation include challenges in processing speed, learning new information, all of the crystallized intelligence things we talked about early on in the talk.
I have another question here, and it says, given the last comments about moderate exercise, what are your thoughts on the importance of community groups advocating for walkable communities, public transportation, etc.? And how important are these better designed communities for aging, mental health, and overall health?
Well, they're critically important. And what we see, for example, one of our junior faculty members at his name is Danny Jimenez, is doing a study called HOLA, healthy older Latinos are active. So anyone who is of Hispanic background and is 60 years or older can sign up for this study. What we're discovering, what we knew when we wrote this grant proposal, is that older Latinos are more likely to be living in less walkable communities than older non-Latinos. So for example, it's harder to walk around in Allapattah than Miami Beach. The Boca Raton is very walkable, and other parts of the area are less so. So it's absolutely critical, because if you have to drive your car to take a walk, you won't wind up doing it. And communities have to be walkable, because given the weather in Florida in the summer, you can't be miles and miles away from your house when you're taking a walk, because you could get swept away by the rain. So advocating for the accessibility of very basic activity, just walking, access to sidewalks and parks is a central thing that's really important. You shouldn't have to take the train to take a walk.
I have
and we all know that Florida unpredictable weather.
Yeah.
I have another question, and it's representing the Asian American communities, and he's wondering, are there any studies or results available in other languages?
Well, we have primarily been working in we've been working in English and Spanish here. However, there's a lot of work on cognitive remediation occurring in China and in Japan and in Taiwan and in Korea and other Asian countries. So a lot of the stuff is now being published in English, but I'm not aware of any local research focusing on that. In our first study that we did, where we recruited 151 older people, 2 of the people who volunteered to be in our study were Asian. So it's we're not coming into contact with that, but it is something that is available. There are Chinese, Japanese language cognitive training software packages fully available.
Someone asked if CRT is offered to people with autism.
We actually did a study of basically autism spectrum disorder and skills competence. And although people think, first of all, that younger people overall are better with technology, and that autism spectrum disorders are primarily social, what we found was that young adults with autism spectrum disorders had a very hard time adaptively using the ATM, the ticket machine, things like that. So obviously the interventions would have been offered in the past, and to the extent that impairments are cognitive, it works. In fact, some people have done research on social cognitive interventions. Simon Baron-Cohen, who's one of the a well-known British researcher in autism spectrum disorders, has developed a computerized cognitive training program to improve social functioning in people with autism spectrum disorders. And Brain HQ has just released a new training program called Socialville, which is aimed at treating people how to recognize emotions and manage social interactions. It's buried in the Brain HQ package because a lot of people don't want to do it, but if you get Brain HQ, they will send you a code to unlock it.
That's great. Can you explain the relationship between progressive hearing loss and dementia? Does it involve primary deterioration in brain circuitry, or is it secondary to social isolation?
That's an interesting question. I had a very personal experience with that. My grandmother lived to 102. But what happened was and she was cognitively intact all the way up through, but what happened was 2 things happened. She had fairly significant hearing loss. And also when she was 85 years old, she had sagging eyes. So they gave her a surgical procedure to lift her eyelids up, figuring it'll be good for 10 years. That should be no problem. Well, what happened was with her eyelids sagged down, so her eyes were closed, and her hearing loss was pretty profound. So it was impossible to tell if she had developed dementia or just had no idea who she was interacting with. Social isolation is a major factor as you start to get hearing loss. And from a functional perspective, if you can't see and you can't hear, what you're able to do cognitively is not a measurable process anyway. So I think that we need that, this is why it's sort of shocking that hearing is not treated the same way as vision, that you're supposed to pay cash for your hearing aids, but everyone has vision insurance. So it's an important topic. There is clearly a relationship between having a dementia diagnosis and progressive hearing loss, and it's something that needs to be intervened on as early as possible, because if it does in fact have a direct impact, then you'd want to avert that to the extent that you could. Plus, a lot of the training exercises we do have auditory and visual components. You can't, what other stream is there to train in cognitively?
Right.
I have a question.
Oh, yeah.
For myself, in fact. At what age should we ask our doctors to do an A1C test so that we can help avoid cognitive decline? Because it's not a typical test being done.
Interesting. Well, I would say that you should start getting your doctor to test both your CRP and your hemoglobin A1C when you're 50, right? And immediately, if you have a fasting glucose that hits 100, ever. Because remember, A1C is cumulative. So you can, if you have a fasting glucose of 101, but your A1C is 2.5, well then it's not because you've had a chronic problem with fasting blood sugars. But it doesn't add much. If you got health insurance, it does not add much to the cost of that. I had that done not this year, but last year, and I didn't have it repeated because the results were all right. But I think that anything like that should be done when you're 50.
One of the other questions we have, I think, Kate, is, would you recommend meditation? And I would. So I'd like to hear what you have to say.
Absolutely. Talk about stress reduction. Walking is really good stress reduction, but every now and then, a lot of people meditate every day. A lot of us choose to exercise every day instead and spend our time doing that. The end state is probably the same if you exercise the right way, but everyone is going to have times where exercise is less possible than meditation.
And on that note, Kate is working with a meditation expert. So we should be having twice monthly free meditation online. And so we will be sending out an email and it will be on our website. So Laurel, who asked that question, keep an eye out for when we're having that meditation.
And
yes, we'll be starting that in April.
And meditation is a skill that you can learn and self-administer at a level that's adequate to have it work for you after just a couple of go-rounds. It's sort of like if you use the right strategies, it's about as challenging as walking. And that's why it's nice to see that walking is such a good exercise for you.
Another question is about support groups. And so I saw it pop up and I can't find it now, but I think it was, how do you find whether support groups help in any of this? So whether it's for elderly or younger folks, do support groups help with cognition, ultimately cognition?
Well, support groups may work if you're getting another intervention as well. But in most of our studies, we use a support group as the inactive control. So the idea would be that if you are getting cognitive training or you're getting exercise or you're doing some other self-improvement thing, a support group targeting engagement and maintenance in those activities is a really good idea. And in fact, some cognitive training programs mandate, bi-weekly support groups where you meet and discuss how you're using your skills. But a support group that just sits around talking about how good it is to do diet and exercise, that's our inactive treatment condition because it's been shown repeatedly not to have any beneficial effect. It's one of those things that by itself, it doesn't do anything for you. Added on to any one of a half a dozen other things, it augments the effect.
So perhaps if NAMI were to have a support group for weight loss and to have in conjunction with a walking
yes
program.
That is exactly the joint thing that works. If you got someone doing something and meeting to support it. This study that Dr. Jimenez is doing is exactly that. It's a randomized study where people are being randomized to getting support versus walking plus support. And in the pilot data, walking plus support smoked support by about, a threefold factor. So, a lot of things are good with something else, but if that's all you're doing, it's not engaging the process that you need to be exercising. It's not engaging the brain activity. It's not engaging the exercise activity, but it's a good support for that. Because when you think about it, and this is I've got a guy I work with all the time. His name is Martin Strasnick. He's a psychiatrist. He's medical director at Palm Beach County Mental Health, and he's a UM faculty member. He points out that, diet and exercise only works together, and that you have to have support in diet, because if you have lunch at 7-Eleven, sometimes you'd have to walk 50 miles to burn up those calories, right? You have a 64-ounce Coke, 2 hot dogs, and a 12-ounce bag of chips, and you have to walk to Boca and back from Miami.
So would you consider, especially now because of COVID and the isolation that's going on, and if people have a fear to go out, as a number of people do, would going to, for instance, NAMI support groups help that if there's nothing else they can do?
Well, if you're not exercising, you're not going to get the exercise benefits. Now, it might be able to get people to not be afraid to go out, because if you are wearing a mask and you are not engaging in certain intentionally risky activities, there's nothing to be afraid of going out, right? If you put a mask on and you go walking anywhere in Dade County, you can socially distance. And then if you've got a mask on, you're socially distanced, you've met your goals, right? There's nothing to be afraid of. I have 2 of the most paranoid people in the world in my family worried about COVID. They're exercising every day, right? They're not afraid to go out. They're just crossing the street when someone's coming. And if we were in a more congested place, they'd be wearing a mask when they were walking. Under Armour sells a mask that you can run in. It costs $20, right?
Sounds great. So I'm cognizant of your time, and I want to thank you for sharing your knowledge and your time with us tonight and allowing us to share the recording, because people are going to love it. And I also want to remind our community that we will be sending out the recording, so you will get an email because you have registered for this program. And we're also going to be sending out the studies that Dr. Harvey has talked about, and we're going to send you information about that first walk for mental health in Miami that will be taking place on May 22nd. And we invite you to join our walk committee, and I'll be sending out information about that. And if you have any questions at all, please send an email to us or Kate Edelson here at namimiami.org. So it's Kate at namimiami.org, or call us at 305-665-2540. And I'm going to put in Dr. Harvey's information so you don't have to worry about that. And thank you, Dr. Harvey. It's been great. Love it.
You're welcome.
Thank you all for coming tonight.
And I'll come back and see you again soon.
I'm going to invite
Sounds good.
Perfect.
you. Take care. Bye-bye.
Thank you very much, everyone.